Okay, I think we can start. So welcome everybody to the Grand Round from Imperial for all three sites. So today it's going to be a mix of endocrinology and cardiology, and we've got three sets of cases. The first, as you can see, is going to be hypokalaemia. The second will be an intriguing cardiac rate problem, and the third will be a very old case that I presented when I was Graham Davis's SHO in 1989. And then a follow-up of that. Anyway, first of all, over to our first speaker, Pusha Bahari.
Hello, everyone. So thank you for joining us for the first case today. So this is a case of a severe hypokalemia. Okay, so this was a 23-year-old male. He was an international student from Australia of Chinese ethnicity. And he just arrived in the UK only 3 weeks before he was actually admitted. And he came here to do a master's degree. And at that time, he was staying in a hostel. So he presented in March, essentially waking up in the morning and unable to move his arm and his legs. So he couldn't even use his phone to call for help and had to literally shout, and the hostel staff came and called the ambulance. So the previous day, he gave us a history of doing high intensity workouts, so lots of push-ups and squats. He also ate a large plate of spaghetti, so quite a lot of carb load, and he has been trying to gain weight, but not able really to achieve that. And also, in the evening before going to bed on that day, he did have some leg cramps, but did not think much of it. So other history of note, he was a fit and well gentleman. He did have 2 previous episodes of leg weakness in the same year, which self-terminated, so he never really felt the need to seek any medical attention. There was no family history of similar problems, and his mother had some thyroid problems. He himself, he was quite well. He did not have any recent illness or fever or even COVID, because that was the time where COVID was at its surge. And he was a non-smoker, no alcohol, did not take drugs or any regular medication. So on examination in ED, he was found to be very weak in his arms and legs. So upper limb and lower limb examination, power was 2 to 3. However, neck movement was preserved and eye movement was also preserved. So it was all literally more distal weakness. He was areflexic with a normal sensation. There was no muscle tenderness and no rash. And his heart, chest, and abdomen examination was all normal. In terms of his observation, he was apyrexal, but he was tachycardic up to a rate of 120. Saturation was fine and his blood pressure was also normal. So one of his first investigation that was done was a VBG, and as you can appreciate here, he did have very severe hypokalemia with a potassium of 1.6. His blood at this point was still pending. So his ECG showed quite a few abnormalities. So the first thing I've highlighted here is the tachycardia, so a rate of 109 per minute. The red arrows is pointing towards prominent U waves. As you can see, leads V3, V4, V5, possibly V6 as well. He also had some T wave inversion and similar leads, and possibly mild SD depression in V4, V5 as well. The other abnormality was his prolonged corrected QT interval, which was 651 milliseconds. And from what I understand, that QT is a reflection of the merging of the T wave and the U wave, and essentially showed an apparent prolonged QT. So based on the severe hypokalemia, the symptom he presented with, and the potential triggers with the high carb intake and the exercise, so a diagnosis of hypokalemic periodic paralysis was made. and he was started on 40 millimoles KCl, which was given fairly quickly with an aim of giving it over a couple of hours. And then it got a bit more interesting when the blood test came back, so confirming that his potassium was indeed very low. And that was coupled with low magnesium, which is not unusual. But very interestingly, his thyroid function came back and shows that he was thyrotoxic, completely suppressed TSH, and a T4 of 29. So based on those blood tests, so we did a more focused thyroid history and examination. And he did have weight loss over the last year. As I said before, he was trying to put on weight, not able to do so. There was some excessive sweating, no palpitation that he reported. And on examination, he had the tremor, lead lag was present. There was no grave eye disease per se, a small goiter, and as I said before, he was tachycardic. So then the diagnosis shifted to thyrotoxic periodic paralysis and likely underlying Graves' disease. So we started him on carbimazole and propranolol at this point. Now on this slide, I've just summarized the treatment he received on admission and the timings. So about 1:20, when we found out that his potassium was low on his EEG, he was started quite promptly on 40 millimoles of KCl. And within a couple of hours into the infusion, we realized it was thyrotoxic, so propranolol was also started. And I would say within 3 hours or so in the infusion, a repeat VVG showed that the potassium actually has increased to 4.1, and the serum potassium, which we obtained later on, was 4.9. So later this evening, his weakness completely resolved. So I just wanted to draw your attention on the fact that he actually did not complete a 40 millimoles KCl infusion, but yet his potassium increased from 1.6 to 4.1 within about 3 hours. And it may be that because we started propranolol, that actually helped to shift the potassium from intracellular to his circulation. He did very well, so his potassium stayed normal and his tachycardia improved, and he was discharged the next day. So on this slide, I've just put 2 ECGs. So the first ECG number 1 was when his potassium was very low at 1.6, and ECG number 2 was when his potassium normalized at 4.1. And as you can see with the red arrows, he no longer on ECG number 2 has prominent U wave, but he has an upright T wave. And also his QT on ECG 2 has normalized and is now 441 milliseconds. And that happened very quickly within 3 hours. So just an update on him. So his TSH receptor antibody was elevated, and that is in keeping with the diagnosis of Graves' disease. And he's doing very well on carbimazole. His latest free T4 and free T4 are normalized, and potassium remained very stable, and he himself did not have any further episode of muscle weakness. And that's the end of the case 1.
Thank you very much. Let's just hand over now to Sharon. Do you want to, I'll just stop sharing here and let Sharon share her screen, please. And then we'll just do the second case, which has.
All right.
And then we can discuss them both together.
Okay, can you all see me? Yeah, you got the case.
Thank you.
Okay, brilliant. So hi everyone, I'm Sharon, and I'm one of the IMTs on rotation at Hammersmith Hospital and Charing Cross Hospital. And today I'll be presenting our case, heart racing paralysis, alongside Prof. Tan, med and endocrinology consultant, and Dr. Lefroy, cardiology consultant. And this is a case that came to the heart attack center at Hammersmith Hospital when I was on my cardiology rotation. And then subsequently, I followed him up during my next rotation. So he is a 35-year-old gentleman with Graves' disease, which was diagnosed back in 2017 with positive thyroid stimulating hormone receptor antibodies to a value of 9.6. And on the evening of his presentation, he had had a large meal of burger and chips with his partner. And a couple of hours later, he was in bed, he felt a bit restless, and soon realized he wasn't able to move his feet, and this progressed in an ascending manner. He told his partner to call LAS when he couldn't move his upper limbs and lower limbs at all, understandably frightening. So on arrival, the LAS, the ambulance crew did a 12-lead ECG after noting him to have a fast heart rate on their rapid assessment. And on 12-lead ECG, they noted a broad complex tachycardia, as shown on the slide, and prompted transfer to the heart attack center at Hammersmith Hospital. Whilst en route, he vomited twice, and on arrival, he reported some tight central chest pain. So on arrival to us, we examined him. We noted him to be clammy and peripherally shut down. And once attached to the monitors, he had a heart rate in the range of 140 beats per minute and a systolic blood pressure of more than 110. So he was unable to move his limbs. Motor exam was not tested at that time. He otherwise had an eye opening of 4 and verbal of 5, giving him a GCS 9 out of 9 or 10 out of 15. So initially, he was managed according to our tachycardia protocol, going through the ABCDE approach according to Resus Council UK guidelines. So he was maintaining his own airway. His SATs were adequate. He was hemodynamically stable with a systolic blood pressure of more than 100, even though his heart rate was more than 140 beats per minute at that time. He was cerebrating. He was oriented to time, place, person. And as I said before, GCS 9 out of 9. And then a blood gas was taken at the time of IV access. We sent off some ACS bloods, and a 12-lead ECG was done, all as part of identifying the cause of the tachycardia. So on 12-lead ECG, again, as noted by LAS, we have a tachycardia of 146 beats per minute and broad QRS complexes. And we believe this broad QRS tachycardia was likely ventricular tachycardia and not sinus, as there are some dissociated P waves in the trace. So at that point, we had an arterial blood gas, which showed a potassium of 1.2, and immediately repeated this. We were sure to check it wasn't a spurious result. And this showed a potassium of 1.3. So we started IV potassium replacement. And we did get formal biochemistry back, showing it to be 1.9 a little bit later on. So within the hour of starting the infusion, his chest pain and paralysis had almost resolved entirely. His tachycardia had settled, and the potassium had corrected to around 5 millimoles per liter. So this is our second ECG around 50 minutes later, showing his rhythm slowing down quite nicely. So this to 83 beats per minute, not yet in sinus. We've got some non-sinus beats and features of hypokalaemia now exposed. We actually had a potassium at 520, so just 30 minutes prior to this ECG of about 1.9. So we've got PR Venkbach. We have a QTC that's prolonged to 558 milliseconds, and one could possibly appreciate some U waves here. So the following morning, we had sent off all our ACS bloods, and we started getting some results back. We have a repeat formal potassium, which is now at 4.5 millimoles per liter. And thankfully, our thyroid functions get sent off as part of the ACS protocol. We have a TSH of less than 0.01, a free T3 of 19.7, and a free T4 of 33.9, so it's thyrotoxic. And we also have a troponin that's high at 1,832. So on repeat ECG in the morning and then subsequent ECGs during his stay with us, he remained in sinus. We didn't have dynamic changes on ECG. He didn't have any further chest pain. Thankfully, his paralysis had completely resolved, and potassium remained stable in the range of 4.5 to 5. So following this, whilst he was with us at the cardiac day ward, and for completeness sake, because he had had quite a big rise, we did a complete cardiac workup. So transthoracic echocardiogram, which showed normal biventricular function and had no valvular abnormalities. We did a CT coronary angiogram, which showed unobstructed coronaries, a cardiac MRI showing no features of inflammation, edema, or infiltration or fibrosis. And so relatively reassuring from the cardiac perspective that there's no organic cardiac cause going on. So the diagnosis is thyrotoxic periodic paralysis. And on further inquiry, our patient admitted to more than 2 months of non-compliance to his medications, as he was concerned about taking carbimazole and its effect on his fertility. He had, in fact, been having symptoms of hypothyroidism with heat intolerance and sweating and some palpitations, but he kind of didn't want to admit to this because he didn't want to take his medication. The endocrine team were involved early on during his stay on the cardiac day ward. We had so long-term management involved reinitiating his carbimazole immediately. We had started propranolol, and we had also commenced a short course of oral prednisone to reduce the peripheral conversion of T4 to T3. And then at the time of discharge, our patient followed up with the endocrine team, and I, in fact, rotated onto metabolic medicine team and was lucky enough to follow him up in endocrine clinic. So that was nice for. So compliance to his medication, it remains a bit of a challenge. The most recent set of bloods that we have for this patient, they were done in April, showing that his thyrotoxicosis is settling. They're not entirely normal, but certainly a lot better from where we were. Unfortunately, he has DNA'd his follow-up appointments, and we're struggling to get hold of him. So watch the space. All right, so what is thyrotoxic periodic paralysis? The pathogenesis remains a little bit unclear, but it's thought to be associated with the hyperactivation of the sodium-potassium ATPase pump within the cell membrane. And ordinarily, this pump, sodium-potassium ATPase pump, is responsible for maintaining sodium and potassium electrolyte homeostasis. So thyrotoxicosis leads to an increased catecholamine activity and overstimulation of the beta-2 adrenergic receptors on muscle cells, which is thought to increase that sodium potassium ATPase pump activity, resulting in an intracellular shift of potassium and a reduced serum potassium as a result. And this causes the muscle cells to be unable to depolarize, and therefore causes a transient state of muscle weakness. So probably better demonstrated on this diagram. So we've got increased levels of T4, resulting in an increased adrenergic response, which increases the sodium and potassium ATPase activity, as well as T4 itself independently acting on the sodium potassium ATPase pump, which disrupts the ion channels and causes an intracellular shift of potassium, which causes hypokalaemia in the serum, hyperpolarization, and periodic paralysis follows then. So there are multiple triggers for this, being increased adrenergic activity and insulin release from vigorous exercise, from trauma, from high stress, emotional stress situations, and ingesting a high carbohydrate meal. Our patient had had a high carbohydrate meal, and Dr. Bahari's patient had had vigorous exercise and a high carbohydrate meal. So both quite classic. So in terms of the genetics, so thyrotoxic periodic paralysis is a phenomenon that we see more often in patients of East Asian origin. So our case is slightly unusual. And there are 3 main variants that have been studied: KCNJ2, CACNA1S, and SCN4A. And the diagnostic challenge with patients like ours is needing to distinguish them from hypokalemic periodic paralysis, as it presents pretty much exactly the same way. And it also has the same associated gene variants. So the differentiating factor is that hypokalemic periodic paralysis is not associated with hyperthyroidism. So even though in the acute setting, you would manage them in the same way as we did, and in case one, they did the same, it's crucial to identify thyrotoxic patients, as treating the hyperthyroidism is key to preventing the further episodes of hypokalemia and paralysis. So in terms of the tachyarrhythmia, one of the main reasons for him presenting, both hypokalemia and hyperthyroidism are at play. So hypokalemia can cause an increased arrhythmogenicity because it paradoxically increases the excitability of cardiomyocytes through hyperpolarization of the resting membrane potential. It increases the duration of the action potential, and it also increases the refractory period. So, and it also increases likelihood of ectopic beat formation. Hyperthyroidism will increase calcium uptake at the sarcoplasmic reticulum, which can also result in a spontaneous, uncontrolled release of calcium waves. So both these factors create a pro-arrhythmogenic state, which can result in life-threatening arrhythmia, as was in our case. So our main differential for this gentleman was hypokalemic periodic paralysis, and that was in our initial treating diagnosis until we had formal thyroid results. However, other differentials for paralysis should always be considered. And so the treatment in acute setting is correcting the hypokalemia and settling the tachycardia. And key to this, as Dr. Bahari mentioned, is you should be vigilant for a rebound hyperkalemia during the recovery phase. So cautious IV potassium replacement is important. And then beta blockade with the use of propranolol will reduce the intracellular potassium shift by blunting that adrenergic response. But in essence, the definitive management of this condition involves treating the hyperthyroidism with anti-thyroid medications, or possibly more permanent strategies such as a surgical thyroidectomy or radioiodine therapy. And that is that. Thank you.
Great, thank you very much. Are there any questions from anybody? I think that's, did your patient get beta blocker before that second potassium?
No, he didn't actually.
Because that's quite remarkable. Because
yeah, so it was all driven by just the potassium. So the propranolol was started the morning after.
Right.
I think the thyroid treatment was reintroduced fairly promptly. He was very, very clinically thyrotoxic.
Because if you think about it, 40 millimoles of potassium is nothing. I mean, we give hypokalemic patients with DKA, for example, and that's very different because in DKA you've lost your intracellular potassium. And so we give, I don't know, 1,000 millimoles over the course of about a week to try and keep them normal. So this is different, and it's my hypothesis, and in fact the case I've got is a bit different, but there's a similar mechanism, is that the meals and so on, and the rise in insulin pumps potassium into the cells. That's made worse by the genetics, of course, and then the T3 is a beta receptor sensitizer, so all that pushes more K back into the cells. So basically all that potassium, it's not lost from the patient, it's inside the cells, and when it comes out, it comes straight up. And if you think about it, I think, yes, I've got a slide on this, your intercellular potassium is about 120 millimoles per liter. So a tiny bit comes out, that's the key. I guess that's why it's kind of happened so quickly in both these cases, because it is very quick. And I can't believe that 40 millimoles will be significant. David Lefroy has got his hand up.
Hello, yes. Just on that point, I think just giving it, certainly in our patient, just giving him potassium would have massively, and thereby restoring his skeletal muscle function towards normal, and also possibly restoring his cardiac muscle function towards normal. We don't know whether he had hypokinesia because we didn't do a V scan when he first came in. but anything that happens to skeletal muscle in potentially can also happen to cardiac muscle. So it could have been that when he came in, his left ventricle was really struggling to contract. Those two factors may have led to a very profound adrenergic tone. And therefore, when we gave him potassium and restored his skeletal muscle function and possibly his cardiac muscle function, that itself would have massively lowered his adrenergic tone, and thereby had the effect that giving a beta blocker would have had, even though we hadn't actually given a beta blocker at that point.
Yes, I think so. So some of the effects of, well, reducing the adrenaline, I guess, would have that benefit too.
Exactly, yeah. I mean, our case, I think, has got sort of electrophysiological interest with the ECGs, but I didn't want to sort of go down that particular sidetrack if people weren't that interested. But
no, I think we are. I think we are.
Okay, I think if we've got a bit of time, then Sharon, are you able to show the rest of the slides?
Yeah. Do you want to share your screen again, Tim?
Yeah, there we go. Oh, sorry. That was all right. There we go. Here we go.
So in contrast to the first case, our patient actually presented with a broad QRS complex tachycardia and hence went down a cardiac pathway rather than a sort of general medical admission. And so it therefore sort of triggered thoughts about how we should manage acutely a patient with a broad QRS complex tachycardia. And one of the first challenges is to try and decide whether we're dealing with ventricular tachycardia versus a supraventricular tachycardia, either with a bundle branch block aberrant conduction, or possibly even with pre-excitation due to an accessory pathway. And the second thing which can be relevant to subsequent management of tachycardia is whether we think we're dealing with a reentrant tachycardia, which implies there is some sort of fixed circuit within the heart, which will predispose the patient to future episodes of tachycardia, or whether we're dealing with a situation with enhanced automaticity, and that means a sort of often a small region of the heart which is somehow abnormal due to metabolic or other reasons, and is producing a rapid sequence of electrical pulses and thereby overdriving the heart and taking over the function of the normal pacemaker region of the heart. So those are sort of two things to consider when you're dealing with a patient with an acute broad QRS complex tachycardia. So Sharon, if you could show the next slide, please. So this was the ECG of our patient, and initially there are some features that made me think this was supraventricular, and others made me feel this was ventricular, and I'm still not 100% sure. But it's beyond doubt it's broad QRS, so the cutoff being 128 milliseconds. This is 138. Sorry, the cutoff being 120. This is 138. But it doesn't have a classical right or left bundle branch block pattern, as one would look for in SVT with bundle branch aberrancy. And also it doesn't have obvious upslurring of the QRS complexes that one would expect to see in a patient with some form of pre-excitation. So then when I mean,
could this be explained by potassium alone, or must there be another explanation?
I think in this case, well, we saw our first case that a low potassium doesn't automatically mean you get VT, because the first case I think was clearly sinus tachycardia. So, but yes, you're right. Hypokalaemia, one of the lists of ECG abnormalities it can cause is ventricular tachycardia. So this may all just be, in this particular heart, a response to profound hypokalaemia. Next slide, please. Again, Sharon showed this earlier, just showing where I think you could convince yourself that there are deflections superimposed on the sort of QRS complex and ST segment, which could represent P waves, which are not, they're not seen on every beat, and therefore this electrical activity is dissociated from the main rhythm, and therefore could represent dissociated P waves. They occur at relatively regular intervals, and one of the things, if you're postulating that deflections of this nature are P waves, you want to see that they do measure out at regular intervals. because that adds weight to the fact that this may be due to underlying atrial activity that is slower than the ventricular activity, thereby giving you the diagnosis of VT. Next slide, please. So here I've just put together side by side for sort of clarity the presenting tachycardia ECG with the subsequent 12-lead ECG, which highlights the difference in the QRS complexes. And again, I think there's also quite a profound difference in the QRS axis, again, which favors VT over an SVT mechanism. Next slide, please. So factors favoring VT are the presence of dissociated P waves and the broad and QRS complex morphology, which is atypical. And the next slide, please.
I don't know what just happened. Present from the slide. Oh no. Oh, sorry.
It's all right.
So in the next slide, basically, there was an intermediate stage in the management of this patient, which between having VT and between having sinus rhythm the following day, where he appears to have a sort of mixture of two different populations of QRS complex, some of which are probably more sinus. So if you look at the ECG labeled 05.54, and at this time his potassium on Cerner was only a few minutes earlier, still measured at below 2. I don't know if that was the true timing, but his potassium was still low. You can see that if you look at the rhythm strip in the bottom, there are some QRS complexes for the first 6 beats that are predominantly negative, and then suddenly they switch to a positive for the next 3 beats. Then there's a sort of an intermediate, which is possibly some sort of fusion, and then it goes back to the negative. So suggests there are 2 populations of QRS complexes. I think the 3 that you see up that are predominantly upwards are possibly sinus in origin. And if you look in V1, V2, and V3 on those 3 beats, you can see a probable P wave, but very, very long PR interval. And then the next beat, the PR interval is very prolonged, and the QRS complex is different. So that may actually be a blocked beat and some sort of Venkebark type pattern. So this and the QT interval you can see is long and measures well over 500. So this ECG is now the first ECG. We couldn't see any of the classical features of hypokalemia, but now we're starting to see them. And then obviously the third ECG the next day is pretty much back to normal, apart from a little bit of ST segment elevation. So next slide, please. I'm just about done. So those are the sort of ECG changes of hypokalemia when the patient's in sinus rhythm. Next, please. And then what we saw was his heart rate did this over the few hours after admission. So there was a sudden drop, which represented a sort of fairly prompt termination of the rapid tachycardia when potassium was started. But then after that, there was a bit of a tachycardia which gradually slowed down. This was when he was in this sort of combination between sinus rhythm and ventricular ectopic rhythm, and that gradually slowed down, suggesting that at least for this tachycardia, this was more likely to be a sort of enhanced automaticity rather than a re-entrant circuit. The first tachycardia, I don't think one can be completely sure either way. So the point I'm making a bit of an issue about this, because VT in isolation has a sinister prognosis, obviously. But in this case, I think we can attribute it all to the hypokalemia. I don't think we're obviously reassured by his other cardiac investigations coming back normal. The troponin rise is of interest. Whether this again represents some sort of acute muscle, cardiac muscle stress. Interesting, his CK was normal, so this troponin is almost certainly cardiac in origin. And whether this was some sort of acute cardiac muscle stress related to hypokalemia, I guess that's the most likely explanation.
Thank you very much. There's an ECG comment from Peter Bordillan about program having a problem in the QT interval with the U wave, and there's a correction that he's put into the chat. Thank you very much, everybody, for that case. I've got another case that I presented over 30 years ago when I was an SHO in cardiology, which I thought I'd share with you for historical reasons. It's got I've got two cases, in fact. One of them overlaps. We did both of these at the staff round in 1989. So this first patient was a patient with mitral stenosis. Now in those days, this is when angiograms were a new thing. All the patients had to be seen by the SHO pre-angio. And one of the things that we were taught as finals is that beta blockers were absolutely contraindicated in heart failure. Okay, that's normal heart failure. And the message we were told was that you need your adrenergic drive to keep your heart going in severe heart failure. And this is true, of course, still. If you have pulmonary edema, beta blockers will kill the patient. But it was so heavily believed that if you mentioned the word beta blocker in finals, in a patient with heart failure, you would fail finals. That was the kind of mantra that was out there. Okay, and I think it's changed a lot in the last 30 years, of course, because we use beta blockers in early heart failure. But that was the mantra. I'll just tell you that now. So the patient was one of these patients admitted for an angiogram, routine, with known mitral stenosis and a bit of exertional dyspnea. And in those days, people managed chest pain with things like bed rest and no management. This is almost pre-aspirin as a known therapy. And of course, I don't know if you know this is a long time ago, but all patients who came for angios in those days were given pre-med of something that was called omnipon and scopolamine. Now, some of you will know what this is, but many of you won't know what that is. So this was from 1936, and everybody in 1989 got this as a pre-med, okay? And it's basically a mixture of hyoscine and an opiate. And you'll notice this is the pre-med, this is the anesthetic literature. It says if this is given 1 hour before operation, the patient has a very pleasant period before any other drug is employed. And so this was kind of the initiation of the pre-med, but everybody got it. And so did my patient. I prescribed it, I wrote it up. So it's basically papaverine, which is a mixture of morphine, codeine, and papaverine. And scopolamine is actually hyoscine. Now, hyoscine was used to dry secretion. It's an antimuscarinic, a bit like atropine. And so their mouth gets a bit dry. And of course, it increases your heart rate, which is not a good thing, as I didn't know in 1989. And of course, what happened to this poor patient? Because she had mitral stenosis, and because we increased her heart rate, and because the valve was quite stenosed, the ventricle couldn't fill rapidly through the mitral valve. And so if you speed it up, you get less and less diastolic filling time. So of course, the patient went into acute heart failure on the way around to the cath lab. So when she arrived in the cath lab, where Graham Davis was ready to cath her, she couldn't lie flat for the angiogram because she was so gasping for breath. And that was, as I said, because the ventricle was not filling adequately. And I'd taken the patient around there. It was a bit embarrassing, very awkward. And I observed him administer 1 milligram of IV propranolol, which I thought was contraindicated in heart failure. And it was like magic, really. Her pulmonary edema disappeared. And you can't use IV propranolol anymore, just to say. So in a similar situation now, I guess we're using metoprolol, but I'll show you why I've mentioned that in my second case. So what I learned from Graham Davis was that, because we always talked in these patients about high output cardiac failure, but he said there's no such thing as that. If your heart is failing, then the output is low, okay? And so although the rate is high, the actual cardiac output falls, because that's the definition, of course, of heart failure. And so, of course, the first lesson here is that mitral stenosis can cause a rate-dependent failure. And if you increase their rate, you can get into a vicious circle of real trouble. Now, the reason I've told you this is I've got another case in 2020, okay? And this is a patient who presented to our casualty at Charing Cross, breathless with palpitations, and obviously had on examination, but had never seen a doctor about it, Graves' eye disease, okay? And she presented breathless, gasping, with a pulse of 190 and a blood pressure 80/40. And of course, she was clearly in pulmonary edema. And because of, you could see her eyes, we knew she was going to be toxic. And the results came back very quickly with a very, very toxic, not slight toxic. This is a sort of thyroid storm type levels. Now, thyroid storm is a clinical diagnosis, but she had it because she had pulmonary edema, breathlessness, heart failure, couldn't lie flat, and she was hyperthyroid. She just had a tachycardia on the ECG. I haven't got it here, but that's all it had. Now, the thing is that she was clearly in pulmonary edema. And it's, again, another cause of a rate-dependent failure in that she had hyperthyroidism. And people say that the demands of the body are more and therefore the cardiac output goes up. But in fact, when they go into heart failure, it's not because the output has gone up. The output then starts to fall because the rate goes up to such a high level that there's insufficient diastolic filling time. And so you want to slow them down, which seems paradoxical in patients who've got heart failure. So this has brought around a question in the endocrine circles: what's the optimum heart rate for someone who comes in thyroid storm gasping? Is it safe to give them a beta blocker, or might you cause the dangerous pulmonary edema that we talked about years ago? Okay, and of course, the situation is if you go above a certain number, let's say 170, if you go way above that, so it's actually an arrhythmia, you're going so fast, then there is insufficient filling time. And so if you slow the heart rate down to about 170, which I think is at this age the optimum heart rate for a good cardiac output, then you might make the patient better. So the difficulty, of course, in some of this age is they might have ischemic heart disease causing normal heart failure, and then the beta blocker would be a disaster. So one of the things you might think about, if they've got a really high rate, this was 190, this patient. So we thought, let's give them a beta blocker. Now, of course, when you give a beta blocker to someone who is hypotensive, everyone gets really nervous. And of course, the cardiologists who normally love beta blockers for things like AF, sometimes will switch patients to digoxin, because that, of course, doesn't cause hypotension, it's thought. So beta blockers can be dangerous, but you need to be confident and certain. And so this is a question that I'm not sure of the answer to. Maybe David might have some thoughts. But if the patient has got a rate that's really, really high, then I think a beta blocker might be a good idea. But if it's not above 170, then maybe you might treat them traditionally as a heart failure patient. Now, as I mentioned, we don't have propranolol 1 milligram IV anymore. Propranolol used to be used, but 40 is the oral dose. It's got a very high first pass metabolism. So IV is a much, much lower dose, but I've discovered you can't get it. So we used metoprolol in this patient. And the thing to do is give 5 milligrams as a slow bolus, and you repeat that up to 15 milligrams until the patient's heart failure is under control. And that's what happened. We gave her some IV beta blockade, and her blood pressure came up, and everyone heaved a sigh of relief, including me. So this, by definition, is thyroid storm. And I'll just say that to define thyroid storm, it's anybody who is thyrotoxic who has got 2 or more of the features on the screen. So a really high temperature, an arrhythmia, which I think our patient had, heart failure, which she had, or confusion or delirium, or liver dysfunction. Any 2 of those will be defined thyroid storm. And I say that because if you are admitted or seen in hospital with hyperthyroidism and you haven't got 2 of those things, then however you're mismanaged, you'll be fine. But the minute you get 2 of those, you have a rising mortality if mismanaged, and therefore you've got to be very careful. The guidelines say manage on intensive care, but we never have enough ITU beds to do that, so they manage on medical wards. So the other thing is that T3 is a beta receptor sensitizer, both in the first case and in this case. And although you have normal, or in fact low adrenaline levels sometimes, the T3 makes your heart rate go up. And if you ask patients who are hyperthyroid, they'll say, if I sit really quiet, I might be okay. But the minute I climb stairs, I get palpitations. And that's because their beta receptors are really sensitive to a really small rise in adrenaline. So beta blockade is the logical treatment for thyroid storm as a first line. So this is a cartoon that I found that explains both cases really, because here's your beta receptor up here, and of course it activates cyclic AMP, which then of course targets these receptors. But similarly, you've got T3, which also activates this same ion channel, which in addition to increasing the heart rate also pumps potassium into every cell in the body, okay? Because of course, all of your cells, when they're anabolic, suck in a bit of potassium. And so if that happens, you have a large carbohydrate meal, and that pumps a bit of potassium in, and then you exercise, and then you suddenly present with hypokalaemia. The minute you reduce the adrenaline or you block the beta receptor, then all this will disappear, or you just reduce the amount of adrenaline, as in the second case, and the potassium will come out of the cells. And remember, the potassium inside the cell is really high. And so beta blockade is logical for both cases. And in the case of thyroid storm, I would beta block them down to a rate of 170, but maybe not go lower, because what I don't want to cause is classical pulmonary edema. And I'll just go through a few other things about managing these patients. So if you see someone who's in thyroid storm, the first treatment is a beta blocker, and high dose very frequently. And that's because if you've got a very active liver, because your thyroid is very overactive, then propranolol orally, any drug orally, its first pass metabolism is rapid, is highly increased. So you need much, much more frequent dosing. So 4 hourly, the only contraindication is acute severe asthma or asthma, in which case we get really scared, and then we move on to the second and third line treatments. So now we wouldn't use propranolol orally, use IV metoprolol up to 15 milligrams, and then you continue with the oral propranolol. Then you want to give an antithyroid drug, and this is a very high dose, 250 milligrams, very frequently, because normally it's a once daily drug, but the liver clears it really rapidly for really toxic, so you need much, much, much higher doses. Once you've given the PTU, you can wait for an hour. Now, by this point, most patients are fine, and you don't need to go to the next stage usually, okay? At this point, in fact, the beta blocker normally sorts out the patient in most cases. But if not, and you need to move on further, then you've got the option of giving them iodine. Now, iodine obviously will be activated if you give it time. So if you've got to give the PTU first and block the organification of the iodine, and then you can give either Lugol's iodine, or these days we give potassium iodide 60 milligrams 3 times daily. Or in fact, I've just heard from pharmacy that it's now 65 milligrams, because that's about 1/10 the cost of 60 milligrams, and it's just been licensed for this, okay? So 65 milligrams as of this week. But you must wait for an hour after PTU before you do that. And then, as we heard in the other case, she got a short course of pred, because prednisolone blocks T4 to T3 conversion. This is the active hormone that causes all the trouble that we see. Never use aspirin in these patients, because it displaces T4 from its binding globulin, slightly increases the free T4. Okay, so this is just a reminder that the amount of potassium inside the cell is really quite high, okay? And so outside, you've got sodium 140, potassium 5 normally, and it's pumped in by the ATPase. And of course, that's activated by beta agonism, okay? And so if you block that, then the potassium of 140 inside the cell, all you need to leak out 5 of those, and you'll normalize the potassium really quickly. And if all your cells are doing it, it won't take long. And remember that in DKA, the difference is that you've lost all this as well in the weeks preceding your admission with DKA. So that's why it's so different. You need so much more K, because you need to give all enough potassium to fill up the cell, as well as replace their extracellular potassium. I was looking around for evidence, and I found some really quite dodgy research. So this is giving 9 healthy volunteers intravenous adrenaline to levels similar to those found after an acute myocardial infarction. Okay, this wouldn't happen today. It's 1986. So to summarize this, there's 9 volunteers. They studied them 3 times. They gave them, with this adrenaline, either placebo or atenolol or timolol to block the adrenaline to see what happened. And to summarize, the potassium in placebo went down with adrenaline, as you expect. With a beta blocker, went down less, but with a beta 2 blocker as well, it's completely, in fact, it goes up. So that's the evidence that the beta 2 receptor is the really important one in being sensitized by adrenaline and causing the fall in potassium. Okay, and then a couple other things about features of hyperthyroidism, and that is, it's clear that really adrenaline is the thing that causes the potassium to go into the cells and increase the catecholamian effects. Okay, so I'm going to leave you then with that ATPA slide and take any questions about either of those cases and say thank you all very much for listening. Any questions? I'm going to share myself now.
Thank you, Karim. That's really, really interesting. I think it does highlight the difficulty in the management of these cases, because the first thing you normally see is the potassium level. And when we push lots of potassium, there's obviously, because it's all the intracellular shift, and then you get the shift of potassium back out, there's a risk of hypokalemia in these patients. So a good learning point for us anyway, in terms of treating these arrhythmias related to TTP. Our gentleman actually remains thyrotoxic. He's now lost to follow-up, so I don't know whether we'll see him being blue lighted back in again. We're struggling with he's missed the last 2 appointments, so we've been trying to contact him.
Yes, David.
So just, you alluded to the sort of relationship between heart rate and sort of cardiac output, stroke, left atrial pressure, and pulmonary edema. It's not a straightforward relationship. And I think the bottom line is that high heart rates are generally bad in patients in cardiovascular difficulty. And I don't know if you're saying that thyrotoxic storm is a special case and you want to keep high heart rates, but as it's some sort of adaptive response. No. I would feel very uncomfortable with that sort of recommendation.
No, not at all. What I really mean is that's the cause of their problem, and you want to knock them down until their cardiac output improves. What I wasn't sure about, how when you see a patient who's got thyroid storm, they might also have ischemic heart disease, and that would make me a bit nervous. I want to use a beta blocker, but I'm a bit, for the thyroid, I definitely would want to give them as much as possible. I must say, yes, that is true. I do remember Graham Davis a long time ago saying the fewer heartbeats this patient has, the better.
Well, I think that probably is generally true. And I think if you see patients in pulmonary edema with tachycardia, whatever the cause is, then I think you're quite within your rights to get the heart rate down by whatever means, even if that includes a beta blocker. I see someone in the chat mentioned esmolol. I think that's an excellent suggestion because of its, if you're worried about losing blood pressure, then at least esmolol is short acting. And obviously there are other drugs to slow heart rate, as you already alluded to, like digoxin and so on. But I don't think this sort of idea that if someone's heart is beating twice as fast, their cardiac output is therefore twice as high is simply not correct. And we see in the cath lab when we pace hearts, actually, the blood pressure drops. I know blood pressure doesn't equal cardiac output, but tissue perfusion is going to go with blood pressure to some extent. And high heart rates in patients who are compromised are generally not a good thing.
Yes, I mean, I think in the cath lab, giving a beta blocker is a very safe thing to do compared to on the general medical ward, when we can't control the situation if we lose it.
Sure.
The other interesting thing I wanted to just talk for a minute about with Tricia was the difference between the thyroid version of this and then the normal hypokalemic one, which without thyroid disease, because I wonder whether it's the same problem and there's no association, just that if you have hyperthyroidism, then you've got an added factor to pump that potassium into the cells. And maybe just the same disease in someone who happens to have Graves' disease, because it's a bit odd because they all seem to have Graves' disease, and that's because Graves is the one that gives you a really, really high T3 or T4, whereas, the non-thyroid goiters, they're not that aggressive. I wonder whether it's simply the same disease in someone who's hyperthyroid. I don't think anyone knows. Do you know?
No, I think we need to study this. So I'm trying to discuss this with our geneticists, actually, because, in hypokalemic periodic paralysis versus TPP, is that I think it's associated with the same genes but different polymorphisms, and what exactly are the links is difficult to say. I mean, you do have your clusters of Asian population where you actually see this problem in up to about 2% of the thyrotoxic patients, and the problem is treated once the thyrotoxicosis is treated. So, yeah, I think...
And you normalize their thyroid, and then you give them a large carbohydrate meal and exercise a lot.
Yeah. It's a yeah. I mean, you know, we don't see many of these cases, whether sometimes they resolve on their own, but certainly I think it'll be interesting to study and to try and pull these cases.
Okay. Any other thoughts or questions from the cardiologists or the general physicians? I don't know if Liz wants to say anything about next week's Grand Round.
Yeah, I will. Yes, please all join and spread the word. So we're celebrating Ten Fazy, who is a stalwart at the staff round, an extremely senior researcher at Meeran, who was recently awarded an FRS, and they're not given out lightly. So we have a staff round with Prof. Matthew Pickering and Prof. Phil Bennett presenting relevant cases, and 10 presenting some of her work. So it should be very special, and it's the last one of term, and then we've got a long break till October. So please do join. Just a shame we can't do it in person with a bit of bubbly, but there you go.
Great, thank you very much. Okay, I'm going to stop recording and see you all next week.
Thanks. Great cases.
Thank you. They were good. Right.